Okay, so welcome to this next video in which we are discussing the role of the sarcoplasmic reticulum in pathological cardiac hypertrophy. Okay, so we've now discussed the basics of pathological cardiac hypertrophy. We've seen that the cardiomyocytes are going to go from having their normal thickness and length to having a much thicker width, basically, and this is going to lead to the wall of the left ventricle becoming much thicker, impeding in on the chamber of the left ventricle, and temporarily increasing the force with which the muscle cell will contract. However, in the long run, what happens is the force goes back down, and it goes back down to lower than the force production of the original unhypertrophied cardiomyocyte. So what we want to look at is what has changed in these hypertrophied cardiomyocytes. Why is the force that they are capable of generating lower? Okay, right. So let's start off with an experiment that was done in dogs then. So what you do then, and this is rather horrible, but what we're going to do is they took a dog, okay? So we have a dog, we start with a dog, and what we do is we insert a pacemaker into the dog. So a pacemaker is just a device which is going to cause the heart to beat, basically. So it does exactly what the sinoatrial node is supposed to do in the normal heart. So it's going to fire off an action, well, it's going to cause electrical activity to fire along the atria and then down the ventricles, and it's going to cause the heart to beat. So we put in our pacemaker into our dog. So let's just have a picture of our dog. So here is our dog. There's the ears. Here's our dog. How should it be now? There's this leg. Okay, it needs more than 2 legs though, so another leg there, we'll put another leg here. Oh, that leg's gone a bit odd, but never mind. Here's our dog. Right. So, what we do is we insert a pacemaker into the dog. So, let's say here's the dog's heart, and now we've put our pacemaker in here. So that's our pacemaker. And we set the pacemaker to hyperactive mode, basically. So this pacemaker is going to be firing off at a totally outrageous frequency, basically. So our hearts usually beat at 70 times a minute. A dog's heartbeat, I think, is probably faster than that. I don't know exactly what the heartbeat of a dog is. I know an offhand statistic, which is that Alaskan Huskies, I think, the ones that pull sleighs, I think they can get heartbeats of up to around 200 beats per minute. So I suspect that dogs have a higher heart rate than humans, but the point is that whatever the heart rate of a dog is, we're going to set this pacemaker to be beating far more often. So it's going to cause the heart to beat totally too fast. Okay, so there's a fancy word for that. We are going to make the pacemaker produce tachy pacing. So tachy means too fast, and pacing means the pacemaker is going to fire off action potentials far too fast. So it's going to induce electrical activity in the heart at a much too fast frequency. So this heart is going to be firing, it's going to be beating at this massively increased frequency. Okay, so we're giving our dog effectively a tachyarrhythmia or a tachydysrhythmia. Okay, right. So this can lead to pathological remodeling. So if you have a tachydysrhythmia, tachydysrhythmias are also capable of producing pathological cardiac hypertrophy. They're another thing that can lead to it. So we've got a tachydysrhythmia. And just in case there's some people out there who are wondering why I'm not putting arrhythmia, there's a movement basically to try and rename arrhythmias dysrhythmias rather than arrhythmias, because arrhythmia now is being used to mean that you actually have no heartbeat. So the heartbeat has stopped. That's an arrhythmia. Whereas dysrhythmia now means that there's a problem with the rhythm of the heart. Okay, so that's just a new piece of terminology. These would have once been called tachyarrhythmias. Okay, so tachydysrhythmia then. And this is going to lead to pathological cardiac hypertrophy. So exactly what we've just described is going to happen within the dog's heart. The cardiomyocytes are going to undergo pathological cardiac hypertrophy. They're going to undergo this concentric hypertrophy. So loads of the dog's cardiomyocytes are going to undergo concentric hypertrophy, where they increase their width far more than they increase their length. And this, in the short term, leads to those cardiomyocytes having a greater capacity to produce a force. But in the long term, it's going to reduce the ability of those cardiomyocytes to produce a force. Right, so we now have our cardiomyocytes to study, basically. We have these hypertrophied cardiomyocytes. So now what we do for our poor dog is we extract those heart cells. God only knows how. I think probably the dog's going to be put down in this process. So we extract the heart cells from the dog, and what we're going to do is measure the amount of calcium that is in the sarcoplasmic reticulum within these heart cells. So here we have our concentrically hypertrophied cardiomyocyte. Okay, and what we want to see is how much calcium is stored within the lumen of the sarcoplasmic reticulum. So let me just give you a little bit of a reminder of the mechanism by which cardiomyocytes contract. Okay, so we'll briefly go over this. So let's say this is a ventricular cardiomyocyte. So we need a T-tubule here. So I'll just draw a T-tubule in. So ventricular cardiomyocytes have T-tubule structures within their membrane, okay? So if you want intuition for what these are, imagine taking a balloon and then invaginating your fingers into the balloon. The balloon surface, the plastic of the balloon, represents the cell membrane, and when you stick your finger into the balloon, basically you're invaginating the membrane into that sort of space within the balloon. Okay, I might have to draw this. So here's our balloon, okay, and you're sticking your finger into the balloon, so here comes your finger. And basically, the plastic of the balloon is going to be invaginated in a finger-shaped projection. So it's just like that in cells. So the cell membrane is like the surface of the balloon, and this is like a finger-like projection into the cytoplasm of the cell. So this is a T-tubule, and the T within the name T-tubule stands for transverse. And transverse is another word for orthogonal or perpendicular. So basically they're called transverse tubules because they project into the cytoplasm of the cell at a right angle to the plasma membrane, basically. That's why they're called transverse tubules, because they're perpendicular or transverse to the rest of the cell membrane. Now, when an action potential propagates along this cardiomyocyte membrane, what's going to happen is that it's going to cause L-type voltage-gated calcium channels in the membrane to open. And some of these L-type voltage-gated calcium channels will be within the T-tubules. So you'll have these all over the place. They're not just in the T-tubules. So this in pink, this is an L-type voltage-gated calcium channel. So when the electrical potential difference across the membrane depolarizes, these L-type voltage-gated calcium channels, and by the way, an abbreviation for voltage-gated calcium channel is VGCC. So these L-type voltage-gated calcium channels will open, and they'll allow calcium to move in to the cytoplasm of the cell. So calcium is at a much higher level extracellularly than it is intracellularly. In fact, calcium extracellularly is usually around 1.5 millimolar, whereas calcium intracellularly is around 100 nanomolar. So basically, there is a 15,000-fold gradient favoring the movement of calcium into the cell. So when you open these L-type voltage-gated calcium channels, you're most definitely going to get the movement of calcium into the cell. Now, what you then have in close proximity to the membrane of the cell is you have a process sticking off the sarcoplasmic reticulum. And what I've drawn here doesn't really show this, give this true, well, it doesn't really bring this structure truly to life, so I'll give you a better representation of it here. So basically, what basically this gap here is far too big simply because there's the calcium, because I've put the drawing here. But in reality, this plasma membrane and this sarcoplasmic reticulum membrane are going to be completely opposed to one another. They're going to be very, very close. So the sarcoplasmic reticulum has these processes that come off it, and they form these sort of close adherences to the plasma membrane. And this sort of a structure is what's known as a calcium synapse. So this is known as a calcium synapse, and it really is very similar to the synapses between neurons, presynaptic and postsynaptic neurons. Basically, the plasma membrane is like the presynaptic neuron membrane, and the sarcoplasmic reticulum membrane is like the postsynaptic neuron membrane. So the presynaptic neuron, when it the plasma membrane, when it undergoes a action potential, is going to release calcium onto the sarcoplasmic reticulum membrane, and this calcium is going to act just like a neurotransmitter. It's going to diffuse across this space in between the two membranes, which is called the dyadic cleft, so in comparison to the synaptic cleft. So this is the dyadic cleft, and it's going to act on receptors on the sarcoplasmic reticulum membrane. So let's draw one of these receptors here. Okay, so nice in the sarcoplasmic reticulum, right? So let me colour this one in turquoise. So this receptor that the calcium is going to act on is basically the type 2 ryanodine receptor. So let me just put this over here. So this turquoise receptor is the type 2, and because its name is so important, we can put it in Roman numerals. Type 2 ryanodine receptor. Okay, and basically the type 2 ryanodine receptor, in response to calcium, is going to open, basically. So when the calcium diffuses across the dyadic cleft and binds to the type 2 ryanodine receptor, then the type 2 ryanodine receptor is going to open. And this is a very important point. Basically, we know that when calcium goes up in the cytoplasm of a cardiomyocyte, that is what causes that cardiomyocyte to contract. Okay? However, the rise in calcium is not produced by these L-type voltage-gated calcium channels. These let in a tiny amount of calcium. They do not let in enough calcium to cause the spike that actually causes the cardiomyocyte to contract. Instead, what you need to do is amplify up the calcium signal. So the L-type voltage-gated calcium channels let in a little bit of calcium from the extracellular fluid. And by the way, the rise in calcium that occurs in the vicinity of an L-type voltage-gated calcium channel, this little calcium signal here, has a name. It's known as a calcium sparklet. So the L-type voltage-gated calcium channels produce these calcium sparklets in the cytoplasm of the cardiomyocyte. And these calcium sparklets are going to amplify themselves basically by acting on the type 2 ryanodine receptors within the membrane of the sarcoplasmic reticulum. So the calcium is going to bind to the type 2 ryanodine receptors and cause them to open. Okay? And the sarcoplasmic reticulum is an intracellular store of calcium. So there is a lot of calcium stored within the lumen of the sarcoplasmic reticulum. So when you open the the type 2 ryanodine receptor, which by the way is often abbreviated to RYR2 for ryanodine, R for receptor, and then 2 for type 2. Okay, you release calcium from the sarcoplasmic reticulum. And let me just discuss with you the complex proteins nearby the type 2 ryanodine receptor. So, if this is the membrane of the sarcoplasmic reticulum, then here is our type 2 ryanodine receptor here, okay, which is going to open in response to this little bit of calcium from the L-type voltage-gated calcium channels. And it's complexed with some other proteins. So here are two other proteins. And these two other proteins are known as triadin and junctin. So we'll let this one be triadin, and we'll let this one be junctin. Okay, and both triadin and junctin are bound to another protein, so it's going to be difficult for me to show this in the case of junctin because I've drawn this arrow right through where I want to put this other protein. So you have these two other proteins. So now the arrow that I've drawn for junctin looks as though it's pointing to this other protein, which is really annoying. So junctin is the pink protein, the pink rectangle, and triadin is this turquoise rectangle here. Now there is this other protein which I'll colour in light green, which is this circle down here. And this is a protein known as calsequestrin, not junctin. Okay, so this is calsequestrin. So both junctin and triadin have this protein calsequestrin bound to them. And calsequestrin, which is often abbreviated to CSQ, has calcium bound to it. So basically, what this complex achieves is it holds calcium very close to the type 2 ryanodine receptors. So when the type 2 ryanodine receptor opens, calcium will come off the calsequestrin and go out through the lumen of the, through the pore of the type 2 ryanodine receptor into the cytoplasm of the cardiomyocyte. Okay, so this phenomenon of calcium traveling across the dyadic cleft to activate the release of calcium from these type 2 ryanodine receptors, or from the sarcoplasmic reticulum, is known as calcium-induced calcium release, which is a name which makes a lot of sense, because you are getting calcium release which is induced by the calcium that's coming through the L-type voltage-gated calcium channel. Okay, so calcium-induced calcium release, which is often abbreviated to CICR, like so. Okay, right. So, basically, what's going to happen is these L-type voltage-gated calcium channels open and spray a little bit of calcium, known as the calcium sparklet, onto the type 2 ryanodine receptors, which then open in response to that calcium and release the calcium from the SR. And this release of calcium that comes out of the SR, so here comes the calcium out of the SR, this is much larger than the amount of calcium coming in through the L-type voltage-gated calcium channel. And this calcium signal coming out of the SR also has a name. It's known as a calcium spark. Okay, so calcium sparklet is the little calcium signal coming through the L-type voltage-gated calcium channel. It acts via calcium-induced calcium release to cause the calcium spark, which is a much bigger calcium signal. In addition, you also have one final signal which I want to give you the name of, which is the calcium level in the SR goes down, okay? And the name for that calcium level going down process is a calcium scrap, okay? So when the calcium is released from the SR lumen, it means that the calcium in the SR lumen goes down, and this is what's known as a calcium scrap. And you'll notice they just took the last 4 letters of spark, spelt them backwards to get crap, and put the S on the front to make calcium scrap. Right, so we'll continue this discussion in the next video.